receiving from the caudal side come together in the tip point. And tip point we will determine the meeting place the forces with suture, like a thorium is suture, transtomal, averting the lateral cruise. This beautiful nose, because ratio of the lobule and vestibule very important. Fix it, the cephalic and vestibular ratio. For this, you can overlapping the medial cruise like this, and you can support it with a columnar strut graft or any, or maybe septal extension graft. 1,617, very big population, patient, were included to this article. Now I want nasal tip. First, lateral cruise length and dome point were determined in this video. You know, the cephalic resection will be together. You must be careful because the cartilage from the you can the best way for the ratio, fix the ratio of lobule and vestibule. Place the suture by cutting 6 or 8 millimeters in caudal to the dome. You can look at the ratio of the lobule and the vestibule. Then I will try to attend to a meeting at this start today in Ankara, Ankara, morning early. We are waiting for you and end of the May in Istanbul for the 10th all-in-one Congress by the doctor.
Otologist and the new otologist, and he is the founder of inner ear malformation classification.
Good morning, ladies and gentlemen. Before I begin my talk, I would like to express my gratitude for this invitation and thanks for another visit Iraq and Baghdad. I have 3 talks today, and I will start with management of stapes footplate fistula, which is a very important thing, something we can miss, in addition to management of footplate fistula. So what is the importance of stapes footplate fistula? There are 2 things. It is, as you know, is a fatal disease, so the patient may die if we don't notice this. The second thing, if the patient has single-sided deafness, inner ear malformation is very important to diagnose and treat this appropriately. This is a 6-year female patient from Italy, and the patient has normal hearing here. One anomaly, it causes recurrent meningitis, and you know what happened? This normal hearing side got ossified. So the patient was deaf on both sides. This is a very important issue. So inner ear malformations, I will talk about later on today. They are 46% of single-sided and manage this footplate fistula as well. So in this paper, I classified the stapes footplate. So this is normal, this is defect, bony defect, but sometimes we can have a... If the patient has otitis media, it is very easy from the infection passes from the middle ear through the cyst to the inner ear, talk mnemonic. So if we see this on MRI, it is very important. So this is normal footplate tomography and MRI. And if we see an opacity, and this opacity on MRI has the same signal with the inner ear fluids and CSF, this is a stapes footplate cyst. But if the cyst has fluid here, same intensity, this is a cyst that needs to be repaired. This is a leaking fistula. You see a fusion, but the signal intensity is not the same. So this is completely different. In the management, I operated 17 cases and 13. And this is very important that IP1s cause recurrent meningitis. We can approach transcalar, endoral, combined transcanal postauricular and subtotal petrosectomy. I like to use combined transcanal postauricular. I will show 2 videos of this. So usually there is a very tiny opening at the footplate, but this is not sufficient to place a fascia between them. So I like to use a tiny drill to enlarge this opening and finally place a fascia in a not to remove the stapes. So this is a 2-year male patient who had unilateral hearing loss, but he was having meningitis. Here there is an IP1 with fluid in the middle ear. And when we look at the MRI, we see that there is a large cyst with the same intensity. Let's look at the operation. You see this is the cyst coming from the middle ear. This is endoral approach. I like this approach very much. And when we remove this cyst, you see the CSF is coming. So stapes tendon, facial nerve, look at the defect at the stapes footplate. So every time the patient has otitis media, it passes through here very easily. So what I did, I take a piece of fascia into the vestibule through the defect, just as I show you the pictures. And the patient had no more meningitis. So this is the tendon, annular ligament, without any recurrence. So what I learned over time, in the beginning, I was taking out the stapes, but it is much more difficult. Never remove the stapes. And I like to place a continuous lumbar drainage for 4 or 5 days because it lowers the pressure and the fascia stays in place. I did the first case in 2013. Until now, I made 6 simultaneous CI and fistulas. But as I said, stapes should be kept in place and your transcanal approach. The first patient was 17-month-old who was having rhinorrhea and recurrent meningitis. And because of rhinorrhea, neurosurgery performed 2 times exploration filled with fluid, and this is the only side with the cochlea. The other side doesn't have cochlea. So if we do leaking, because of this rhinorrhea, they thought there's a problem in the nose. In fact, the patient has IP1 anomaly with a leaking CSF fistula and put a cochlear implant at the same time. If we put a lot of fascia into the vestibule, we block the cochlea, there is no future chance for cochlear implantation. Therefore, of this patient, whom I operated recently in 2020, because the video is much more explanatory, this poor female were coming to me, but at the same time, congenitally deafness. So we have to fix the footplate fistula plus cochlear implantation. Let's look at the tomography. This is a hypoplasia type 2, but there IP1 anomaly here with the fluid in the middle ear and mastoid. And if you look at the MRI, this is very demonstrative. You see this fluid has the same time through the footplate defect into the middle ear and it's causing meningitis. And I will show you what I did. So this is the mastoidectomy. When you point, I make the facial recess and see this fluid is coming from the foot plate. At this stage, you see, we don't have a direct view to the foot plate. So therefore, I don't do this anymore. I elevate the tympanomeatal flap and do a transcanal approach. So this is the ear canal. I made a... So there is a very tiny fistula. This is the stapes crura, posterior cruza. This is the stapes tendon. We have to enlarge this, otherwise it's impossible to put a fascia. But when we enlarge the foot plate, we keep the stapes in place and place a piece of fascia through here. So this is what I do now. This is a challenging surgery, the cochlear implantation. So now the fascia is in place, very nice control of the leak, but we still have to do cochlear implantation. Then we go to the mastoid, and when we make stopper, this electrode I developed for the CSF leaks, and it has a stopper which efficiently stops the leak, and in one session it lasts about 3 hours. So this is the fistula of the foot plate, and this is the round window area, nicely repaired. We put some fibrin glue, but believe me, the first line of defense, that fascia, is much more important, and this is the postoperative X-ray. So we should never forget that these patients need appropriate cases need every 5 years repeated until the end of adolescence. And the most important factor is the control of the fistula side. Many people says we do subtotal petrosectomy side, and surgeons should not leave the surgery before absolute control of the leak. Lumbar drainage, I keep it in place for 4 or 5 days because this decreases subtotal petrosectomy. In conclusion, if there is meningitis and deafness, please check the tomography. There may be IP1 anomaly in foot plate fistula. Have meningitis, don't wait for meningitis. Go and repair the fistula. Direct approach, endarol, is very efficient because you see the foot plate very well. Stapes, I have done this. It makes the surgery much more complicated. Postoperative continuous lumbar drainage is very important, and some cases may need subtotal petrosectomy.
Thank you, Dr. Levent. I just want to ask, in the oral approach, is it necessary to remove the incus or leave it in place?
No, it is, I never remove. There is the CSF has a huge pressure. It pushes our system outward. And incus and stapes, if we preserve the ossicles, they keep the stapes in place. But if we remove it, very important, just keep it in place. You know, we're all doing stapes surgery. This is just like that. Use a small, tiny drill to penetrate the foot plate. I am sure you also come across these cases as well.
Second question, during cochlear implant, when we face such a case, where there's fistula, can we enlarge the exposure to the stapes?
Yeah. So in the first operation, I didn't show you the video. I did exactly that. But through the facial oblique view, it's not direct. And when it is oblique, I tried to put the fascia through there, but there was a fracture in the stapes, and in the end, I had to through transcanal. We have a direct view of the foot plate, and it is much better to do it that way. Much better. Much precise.
Thank you, sir.
Thank you.
Next lecture is Pediatric Skull-Base Surgery by Dr. Alfred. He's a president of Albania. You have 15 minutes, Doctor.
Good morning, everybody. I want to start my presentation. Just a moment. Okay. I have no conflict of interest to clear. Pediatric endoscopic sinus surgery is a very expanding field. There are other pathologies as congenital atresia and acrocystitis, and we can use even for sinus tumors, skull-base surgery, that we can use the endoscopic sinus surgery, extended endoscopic endonasal approach. I will explain a few considerations about the use routinely a CT scan, because the children are, if they need different CT scan, they can risk radio in. When we need CT angiography for embolization of the GNA, we need to take in consideration even the piriform aperture, because if we have a small aperture technique, we need to use three hands technique, and we need to use even the smaller endoscope than normally. Even when we have pathology less than 8 millimeter, it's very difficult to approach these pathologies through the endoscopic endonasal approach. Even the have a good pneumatization of the sphenoid sinus, we can see our landmarks very well, like interoptico carotic recess or the other. We approach this type of pathology because it's not a one-man surgery. You can do only as an otolaryngologist this type of surgery. You need neurosurgeon, neuroradiology, and big troubles because the complications, especially for craniopharyngiomas, for example, are very common, and you need a very good patient. I will start with simple cases. This is a fibrous dysplasia that we need to operate a small fibrous dysplasia after we expose the maxillary sinus and remove the anterior ethmoid complex. We can approach the tumor. This is the sphenoid sinus. It's clean. We need to remove step by step. Very particularly case, the dysplasia was very soft, and we can remove easily even from the papyracea. We have another case of embolization. It was the first time that I used the coblator in this type of surgery, and I think it was better to use with a very big lesion, and we can do without it. And this is the approach. We need to remove the sinus of the posterior wall, and after we do that, we can spare even the lacrimal duct here. After remove the coblator, and it was a big hemorrhage from the maxillary artery, you need to cauterize the posterior wall of maxillary sinus. We can open the pterygopalatine fossa, the infratemporal fossa. We need to find the artery, maxillary artery, and to cauterize because in this case we don't have an embolization. And after we do this step, the surgery is very easy because it's a small tumor. It's not a very big an error. You can have some troubles, but there is nothing important. And after we are removing here the vaginal canal to the sphenoid roof, and after we remove even the small portion of the pterygoid, we are able to tumor from the pterygoid muscle, and we can remove all the tumor. In this case, I prefer into portion. The first was the intranasal lesion. The second was the infratemporal lesion. It was very isolated and closed the artery. It's very important after the surgery. This is the median artery nerve. We need to drill the basis sphenoid to avoid a big tumor. In this case, we need to embolize the tumor because it is very large tumor, and the strategy is the same because all the infratemporal fossa was involved, and this is the anterior wall of the maxillary sinus. We need to go through the in this case, but our lateral limit is this. This is the maxillary sinus, and we need to enlarge a little bit more laterally because it is very big. And in this case, we open the ethmoid complex, and we remove everything we can remove because we need to isolate full of tumor. This is the mucosa of the posterior wall of the maxillary sinus. This is the bone component, and in this case, we find the lateral portion of the lesion, and this is the infratemporal component of the lesion. We need to put these cottonoids time after time because it can help us to remove the tumor. This is the sphenoid component of the tumor. Even in this case, control very well the pterygoid. This is the intranasal portion of the tumor. We are detaching from removing the tumor in two pieces. It was a very big tumor, 12 10 centimeters, sorry. And we still have this lesion. There is in the foramen ovale. We need a nerve, the B2, and here I'm clipping the maxillary artery. I check with the Doppler if there is any was eroded by the tumor. This is another component that goes to erode all the bone of the basis sphenoid. And after we finished everything, we need to drill and the temporal muscle. And this is a very good result. We don't have any remaining lesion. This is the MRI immediately post-operatory, 24 hours. Sorry, not immediately, because we do it after 24 hours. And this is another case that we used end of this meningocele. The patient had on previous meningitis. This is the reason that the doctors do some. You can see that this is a meningocele that is pulsating. After we start with reducing the meningocele to find the fluorescein very diluted because it is dangerous in pediatric age. This is the meningocele. We need to remove. Okay. We find the defect. We need to remove all the mucosa around to the bone. I'm removing all the mucosa and the periosteum and perichondrium in this side because it's very moidal branch of the lateral wall. We need to cauterize everything, and after that, we neck of the meningocele. This is the final defect that we need to reduce a little bit more, because a small defect, the child was only 2 years old, and I need to be sure that he can't have problem in the isolate better the neck of the meningocele. And I decided to take some cartilage from the septum to close better the defect, because in this case I choose to close with the Haddad flap tillage. And after preparing the cartilage, you need to put underlay this cartilage. It's very delicate procedure. You need to stay a long time, because it's very important, extradural. Okay, this is the anterior part. We need to put even the posterior part underlay. Otherwise, you can't have these results. We have no leakage, because we use the fluorocene for this purpose, to become sure that we don't have any leakage after the closure, posterior part. And this is the final closure, and it goes very well. You don't need to. It's very okay. This is the final result, and everything's go well. This is another case of craniopharyngioma that we use endoscopic and the nasal approach, expanded. Neurosurgeons that have huge experience, you need to avoid.
You have 1 minute, doctor, please.
Okay, the damage of the orbital nerve. And in the last, we need to reconstruct with very good material, because otherwise, because it's a high pressure fistula, and usually it's very difficult to close without 3 or 4 layers. Endoscopic nasal approach for treatment of skull-based lesion in pediatric age. Nowadays, the indications are extended, even in limited. Has the potential to reduce the morbidity of this surgical procedure, because, for example, this child of 2 years old, if we do from the top with neurosurgery approach, it's very damaging. It's very difficult for the children. It is critical, all these type of colleagues around you, to avoid any complication. Thank you.
Thank you, Dr. Wilfred. Now the second lecture is revision of rhinoplasty.
Help.
فيديو ما اخذ فيديو. بلا عنده تايب سي ما كان يجيبه. اخذ.
Thank you. Thank you very much. Good morning, everybody. And ruining the connections of a PC. Okay, so I'm going to talk about revision rib rhinoplasty. I'm Eduardo Morera. In Spain, I work in the mornings in Son Espacios Universitario Hospital, the big hospital on the lower photo. In my afternoons, I work on my private practice in Clínica Juaneda, and this is my contact. And this is Gerona. They have a cathedral, and that's one of the places in Spain where a Game of Thrones was filmed. There were 5 places in Spain where Game of Thrones was filmed. And inside the cathedral, there is this creation we can see in this part when Jehovah created the woman from a rib. And this is the text in Latin, Misit ergo Dominis Deus oporem in Adam. That means when Adam was asleep, Jehovah took his rib and created the woman. So I use the rib on a regular basis, almost 2 times or 3 times per week. Some patients, you don't really think that you will need rib. Like this case, it's we will need an extra cartilage, and the only good source for it, for a solid cartilage, will be rib. Other patients with very thick skin, they have thin nose deformity, they need rib. With cleft palate noses, they need rib. Where trauma patients, they need rib. So we need rib. Say that 10 years ago I didn't use rib that much, but now I'm using it, as I mentioned, 2-3 times per week. It's pretty simple minutes, and the key is that you have to get a large piece of rib, a long piece of rib, and then you have to cut it obliquely because we need 1 millimeter thick. As you may see, the scar is inconspicuous in a few months, but even that I started to do the periareolar, and I learned to do it. And you can take even 2 ribs from the periareolar approach. So there is even no need to leave a scar anymore in a patient when you are harvesting a previous nose surgery, and he complained about a breathing problem, and he had just as valve insufficiency, and internal and external valve insufficiency. So we took the rib. We are doing rib revision rhinoplasty. The first thing you have to do is reconstruct the L strut. The L strut is a key support of the nose, and that goes first for every case. So it was only a small remnant of cartilage in the nasal septum. We did 2 long spreader graft. We inserted them, we fixated them to this remnant of the quadrangular cartilage attached to the anterior nasal spine, and the extended spreader graft to reconstruct the L strut. And then when we have this reconstructed L strut, everything starts to begin. We will add some button graft, some rib button graft, to reinforce the external valve. As you can see, we redrape the soft tissue envelope, and this is the result 1 year after the surgery. So you may see that although the grafts were perfectly. Cleft lip rhinoplasty is one of the most common cases for revision rib, and in has very crooked nose, and we have hypoplastic
hypoplastic cartilage on the cleft side. So we open the nose and we see that there is an asymmetry of the severely crooked. We dissect the mucosa, the skin, and we get a long extended graft. We extend front of the anterior septal angle, and then we should read. We dissect the lateral crura from the skin because it's, and we put this graft that I call an lateral crura extension graft. So we match the length of the lateral crura on the healthy side and the cleft side, and then we put a shield graft, and that ends the procedure. Nostril retraction, and we get a functional nose. Patients with thick skin and thin cartilages are also very common in Spain. We live in a globalized world. The patient is from the Philippines, and she had a previous rhinoplasty. You can see that she has a platyrian nose, a very short and we need to project the nasal tip, so we need a very strong cartilage. Of course, we cannot get any cartilage from the nasal septum previous surgery, and even without that, the quadrangular cartilage of people from Southeast Asia, from Philippines, is very thin, so we wouldn't be able to project the nose and define the nasal shield graft on her nasal tip. In order to project and define the nasal tip, you have to suture it very carefully to the caudal septum with lots of stitches. You have to make sure that the graft will not rotate, and you can see the long-term result, how the nasal tip is thin, and how we have been able to enlarge the columella. Some cases are worse. Like this case, this patient had a facial trauma, ALA. The maxillofacial surgeons initially reduced all the fractures and sutured everything, but after a few months, the patient had this severe twisted nose, and as you can see, he had a missing of the nose, but it looks like a frontal view of the nose because the nose is severely crooked, as you can see from the basal view. So in this case, again, we open the nose, we see that we are missing, we're lacking some, not just skin and cartilage, but also nasal mucosa on the right. Strut, we create two extended spreader grafts, and we should do them to graft. We mince some cartilage with some cartilage scales. We use the fascia lata to cover it all, to raise the nasal dorsum. Then we have this problem with the nasal ala. We do a turnover flap using the skin from the cheek to reconstruct the framework of the nasal ala. We put a shield graft. We close the skin. We have this defect of the skin. So what do? A nasofrontal graft. We'll raise it and we should it in place. This is the patient 2 weeks. We reconstruct the nasal ala, and this is the patient 1 year after the procedure. So the patient now has a normal looking nose in the frontal view on the profile. And this is the barn. And the tip of her nose is not her skin. It's a Tagliacocci flap. She didn't have any nose at all, so a previous surgeon did a great job actually, and he reconstructed all the tip of the nose, just the skin, with the skin of the forearm. So that lady had to stand like one. That skin does not have any cartilage at all, and as you can see, there's only 2 small holes. So this is a small video of the surgery. that we have to design the nostrils because there are no nostrils at all. So with a marker, we design the nostrils, and we will have to cut 2 flaps, one in each side, to cover the framework for the nostrils. To have space for the nasal framework on both sides, I'm dissecting the skin and then I'm opening the nose. And as I mentioned, first thing is these 2 caudal extension graft or ANSA banner bilaterally to provide support for the nasal tip. This is having enough tip support. I start reconstructing the framework of the nasal ala. Insert some bilateral them to this tachograft, so that will make a framework for the nasal ala. Then I put another graft in the nasal dorsum. That starts to look like a nose, more or less. The patient had a very thick nasal alar ring graft and precolumellar graft. So this is the precolumellar graft to create the shape of a columella. And then I'm starting to close the nose to see how the shape is going, because I want to see the relationship between the nasal tip graft and now some ring grafts, because we need a very strong rim support for the nasal ala. So that's a bilateral ring graft on the left side. I put 2 ring grafts on the left side, and on the right side I roll down the skin and cartilage from the concha, as you can see, to cover that defect. You do that in place, and there we go. Now we have a nose, a functioning nose. So when you put this combined graft, you have to put some pressure for a few days, because it's always a risky graft to insert. And this is the patient 2 weeks after surgery. You can see she has a nose, she can breathe, deformities, but you can see that now she has a nose, and, well, gaining a small battle for this lady, for us, is always a great victory. You can see here 3/4 view and the basal view. Thank you very much for your attention, and as I mentioned before, you're all invited to Barcelona.
The lecture is about the classification of inner ear malformations.
And suddenly I come up with a ear presentation, but sorry, this is my job. I do ears only, and this is my main work of interest, inner ear malformations. So I will talk about the malformations of the inner ear. So this is my team, because they contribute a lot to the management of these cases. So when we look at congenital sensorineural hearing loss, 80% are membranous malformations where the anatomy is normal, radiology is patients in the management. So mainly what I'm going to talk about comes from this paper, which is free on the internet, published. We published this in a lot of cases, images, videos, and you can find a lot of case examples devoted to each group in this book. Okay, we started implantation in '97. Until now, we have done almost 3,400 cases, and 617 are with malformation. So 400 breakdown of these cases, not all of them have the same frequency. So the most common is IP2, and the second most common is cochlear hypoplasia. Common indication for ABI. IP2, IP3, and enlarged vestibular aqueduct, they always receive cochlear implantation, so they're definite cochlear implant indication. Mishal rudimentary otosystem, if they have a nerve, they receive cochlear implant. If they don't, they receive ABI. So we have to choose between this. So the classification, I will show you images of each of these malformations. We have 8 categories. These are the definite ABI indications. These are definite cochlear implant decision, not only by imaging. So audiology is very important. We make the decision by audiology and radiology. So if there is a positive response during audiological evaluation, we prefer to do cochlear implantation even though the nerve is not visible. So labyrinth 4% of the malformations, there is no labyrinth. Labyrinth is absent. ABI is the only option. We operated 25 cases with ABI. So this is one example. So this is Mishal deformity. The second group is rudimentary otocyst, where we have a millimetric otic capsule, and there is no internal auditory otic capsule remnant, but we should not try to put a cochlear implant because it will not work in these cases. The third group is cochlear aplasia, where the and ABI is the only option. Here there are 2 different categories. One is cochlear aplasia with normal vestibule, and the other is cochlear posterolateral part, and cochlea, which is anterolateral, is absent. And these patients need ABI. We always do it. This is 11, 10, 9. This is the choroid plexus, which directly leads us to the foramen Luschka. And the whitish tissue here is the ABI electrode into the recess, and this is the ABI procedure. Common cavity is a structure which has a cochlea and vestibule. So there is no separate cochlea and vestibule. This is important. There's 6.7%. Gusher can happen, and sometimes the cochlear vestibule patients. We have to differentiate this from cochlear aplasia with vestibular dilatation. So this is common cavity. Cochlea and vestibule are and we have to differentiate this from cochlear aplasia with dilated vestibule. IEC, internal auditory canal, comes and opens to the center auditory canal, and this is a posteriorly normal location of the vestibule which is dilated. This is the only difference, but we should not make a cochlear implantation here. The nerve entering the common cavity is termed cochleovestibular nerve. It is larger than the facial nerve. So this is the cochleovestibular nerve entering the common cavity. If you look at this patient, we have a CVN here. This is cochleovestibular nerve, but this is very hypoplastic. So I prefer to do ABI here and cochlear implantation on this side. The problem, we make an opening and insert the electrode into the common cavity. So from now on, we have a clear separation between the cochlea and vestibule. If the size of the cochlear partitions, cochlear hypoplasia, smaller than normal cochlea, they are 25%. So 1/4 of the anomalies. We can have some, and sometimes the nerve is absent. They are the second group of cochlear implantation and largest ABI indication. And interestingly, nerve anomaly in this group. There are 4 categories. This is bud-type cochlea, where the outcome of cochlear implantation is not very good. This is cystic type cochlear hypoplasia, basal turn, and tiny apical turn. How are we going to make this diagnosis? If we measure this length, and if this is less than 7.5, to choose proper electrodes. Sometimes we have audiograms like this. They don't need cochlear implantation or anything. Hearing aids are sufficient. Sometimes we have air bone gap. First, I was thinking that this is due to otitis media, but this is due to stapes fixation in cochlear hypoplasia. And I performed stapedotomy, one at the age of 4, one at the age of 5. This is cochlear hypoplasia and very good outcome with stapes surgery. But usually they have always here normal nerve. This is hypoplastic nerve. Always we do cochlear implantation. But this patient, cochlear hypoplasia without a nerve. So this is to make the differentiation between them. We operated 117. Some of them may have gusher. We have to use thin and short electrodes, incomplete partitions, standard electrodes. This is very important. This is an IP1, and this is cochlear hypoplasia 2. They look 7.5. This is less than 7.5. So I choose form 24 for this, form 19 for this. But if we don't make this differentiation like this, if we use form 24 here, the stopper will be out and we will not be able to control the gusher. So proper diagnosis is very important. And is possible, and sometimes we have facial nerve anomalies. I want to show you one example. Look at this patient. The facial nerve is normally located on the promontory, and this is the round window. You can easily damage the facial nerve, but for this patient, I made a groove here, and rested the electrode, so there is no damage to the facial nerve, and then we inserted the electrode nicely into this hypoplastic cochlea. But facial nerve anomaly is very common. The external size is normal, but internal architecture is deficient. There almost 1/3 of the anomalies. So this is the most big group. There are 3 categories: incomplete partition 2, cystic apex, and incomplete partition 3, interscalar septum is present, the whole base is absent. They have 3 clinically. So IP1, no modalis and no interscalar septa, and gusher is 50%, but as I talked in the morning, they are most frequently having meningitis. So if you have recurrent meningitis, think of IP1. So this is a cochlea, no interscalar septum, no modalis, very large. We can have gusher in 30 of them. I developed an electrode which has a stopper to stop the leakage in these anomalies. I want to show you, make the cochleostomy. Look. We have huge CSF leak. So this is CSF gusher. 50% of the cases have this. If we tiny piece of fascia, this is the stopper that I designed. So when we place the electrode, the stopper squeezes the fascia into the opening, and as we see in the video, this is very important. We wait 10 minutes so that there is no CSF leak. IP2 has a vestibule and enlarged vestibular aqueduct. They are 22% of the malformations. So this is a very typical tomography, cystic apex, enlarged vestibular aqueduct, surgical difficulty. And the most important thing is that they have fluctuations and progressive hearing loss. They don't have a fixed hearing level. No matter if they have head trauma, the hearing is progressing. And it is very important. Usually they need cochlear implantation, and pressure is transmitted via vestibular aqueduct into the scala vestibuli, and this creates these modular deformities. So the surgery is very standard, but remember, 8 of these patients had gusher. So 6% may have gusher. I prefer to use the electrode with the stopper for this 2.6%. So gusher is 100%. So we have to be prepared for gusher, no meningitis. They have mixed type hearing loss and also electrode migration. So when we insert the electrode, it can go into the internal auditory canal. Always they have a cochlear nerve, so no ABI is necessary for these cases. And this is a typical audiogram. You think there is an airborne gap. In 1980s, they did stapedotomy, but stapedotomy is prohibited in this. So don't make staple surgery in these patients. We operated 14 patients, all gusher, and we should not use modular hugging electrodes because it goes into the internal auditory canal. Millimeter and above, we call this enlarged vestibular aqueduct, but here the cochlea is normal. If there is cochlear deficiency, we call that IP2 anomaly. And finally, be narrow or aplastic, and as a result, the cochlear nerve is deficient and sometimes absent. So it may result in cochlear nerve hypoplasia, because sometimes the cochlea is normal, but we can have abnormalities here. So if this is 1.5 millimeters, this is normal. This is less than 1.5 stent implantation, but it will not work. As a result, the nerve may be hypoplastic. So on cross-section, the cochlear nerve is absent. So we have to check these before making cochlear implantation to avoid frustration. And sometimes we have extremely thin hypoplastic nerve. What are we going to do? We found that the best management in these cases is to do cochlear implant on one side and ABI on the other side. Because when but together, these patients are much better. And we published our results. We call this bimodal stimulation, and the children have better CAP scores management. So this is my final slide. In Michel, rudimentary otocyst, cochlear aplasia, and cochlear nerve aplasia, we prefer to do ABI. In common cavity, we use foot plate fistula, don't forget, and they can have meningitis. IP3, 100% gusher, no modular hugging electrode, avoid stapedotomy. In IPGA, we have to use short and thin electrodes. Remember facial nerve anomaly, and some cases benefit from stapedotomy. So this is my final image. I saw this beautiful, beautiful image, which is from 4000 BC. And, you know, I was very much happy because I was also interested in normal, incomplete partition, and hypoplastic structures. Thank you very much for your attention.
Thank you very much, Doctor, for nice presentation. Very good. Thank you. Thank you. Total sinus. Dr. Shahzad. Dr. Shahzad. Okay. The next lecture Rhinoplasty. Mr. Powell. Mr. Powell Yazbek from Lebanon Academy and European Academy of Facial Plastic Surgery. You have 15 minutes.
Mr. Chairman, thank you. Thank you, audience, and for the invitation again. Well, it will not include those discussed by Dr. Eduardo, the post-traumatic or the burn or the accidental. It's just for primary or secondary cases. So the most of the patient, if you don't put what you need to do in mind, you cannot have a good surgery. And in order to plan a proper physical outside with endoscopy and definitely proper photography. And all views, face, profile, obliques, up and down, smiling, all these pictures of surgery. Of course, you need to know the anatomy of the bones and the cartilages, and the anatomy of the turbinates, the septum, before fixing only the shape. And when you remove, you need to rearrange. By this, I mean, like when you separate the upper cartilage on spreader flaps or spreader grafts, or reattach them. When you do like laterocrural overlays, you cannot leave them hanging. So every time you cut cartilage or you make things in place. The surgical approaches are many. You have the transcartilaginous, the intercartilaginous, the retrograde, delivery approach, or open rhinoplasty approach. Personally, I like the open approach because you can put grafts easily and you don't need to work through holes or pockets. Graft types are, and during the lecture, you will see SFC, which means structural, functional, or cosmetic. The grafting material, you have the cephalic trim of the lateral crus. The septal cartilage is the best to use during surgery. Ear cartilage is very good, but it's, as you know, second best after septum, but you need to do another surgery to get the rib. Bone and synthetic material, personally, I don't use them. Types of grafts. So first, cosmetic result for tip definition. Septal extension grafts were discussed before, and we will talk about them again. These are structural, cosmetic, and functional. They add support to the tip, they open the airway, and they give tip support. And you can do that as you saw later. And after doing the tongue and groove, you can shave them to give a proper rotation of the tip. Strut graft is the, or if you have tension, downward tension on the tip, because they cannot put the tip in place alone. It is in the medial cruri if they are S-shaped or they are twisted. Strut grafts can be used with a graft and to add additional support to the tip. And this gap in the upper portion, it can be filled with cartilage too. Lateral crural undergrade grafts, these are very important grafts. When you have a patient with a curvature of the lateral crus, and you can see dips in the skin and the lateral breath, and there is collapse of the external nasal valve. And lateral crural stud graft is the underlay graft that will support this deformity. You can put a lateral crural onlay graft where it does the same function as the underlay graft, and this is lateral crural turn flap is when you have also active external nasal valve. You need to free the lateral crus from the underlying mucosa, tuck it under the remaining segment, remaining inferior segment. This will give double thickness of cartilage and will support the valve too. In deformed cartilages, you can try it. If it doesn't work, you can just do a replacement graft. And replacement graft is done in severely sheen graft is the old friend of ours, but personally I don't like it because it always shows apex graft. It opens the valve, further opens the valve. If you do your abdominal sutures and you see that there is still narrowing between the medial pocket, and you put the subdermal apex graft, and then you see that the lateral crus will be pushed little, and this is all we need. Rim grafts, you inject the rims, you make a pocket, and you slip in a piece of cartilage. This will give definition and will give two nostrils. Like one has a little bit of notching, a rim graft will correct this notching. Dorsal onlay graft can be used as also a structural, cosmetic, and functional. Lateral cartilages on it, it opens the valve and covers the dorsal defect. Spreader grafts are our workhorse. We use them basically on every surgery. Spreader grafts are used sometimes alone or in combination with spreader. You can push the tip down when you use them and put a strut in between and over-rotated and over-projected noses. These are spreader flaps. You remove the perichondrium and you put them as a spring effect to open the internal nasal valve. Spreader flaps sometimes are too wide, so you need an aesthetic dorsum. You don't need a too wide dorsum in every patient. And they are easy to put in place because they are in their place. Are a deformity, you can do variations between these two. Okay, then we have the radix graft. This is very important. When you have a patient, the pre-op is the midline. With digital imaging, you can tell if this patient will benefit from a radix graft or you need to take out the bone and follow. If we do a radix graft, which can be used from pieces of cephalic trim, can augment the radix and give her a better shape. We have the camouflage graft. When we remove the perichondrium and the fat from the lateral crury, you can just suspend them through a thread and put them through. These are very important at the conclusion of surgery to have your finishing touches. And of course, the diced cartilage with the blood. And you can spread all these finely diced cartilages everywhere you want to cover minor deformities. Grafts, but be generous when you're putting the grafts where they are needed. Thank you.
Be the external approach to the frontal sinus. Dr. Shahzad.
approaches are becoming less and less common because we are becoming more and more versatile in our ability to reach all aspects of the frontal sinus tension with crossover, with even with a transorbital approach as a multiportal approach. So, but the external approaches, there is still a role, and I thought I would just share some of my frontal sinus. It's a heterogeneous group of both benign and malignant conditions, thankfully mostly benign. It is the most challenging sinus of all of the sinuses and has the greatest potential for persistent and recurrent disease. And sometimes the hardest thing is making that decision whether to explore it or not. And it's a key aspect, as with all surgery, is mass view and to use the IFAC classification of frontal sinus cells and frontal sinus surgery, because we're talking the same language. Coon, a frontoethmoid cell, we need to talk the same language. And for most of us that are now doing frontal sinus surgery, we use the IFAC classification to understand and to use. So my talk's about external approaches, and the simplest is the frontal trephine. There is still a role. It's an incision aspect of the eyebrow, because I think going through the eyebrow leaves an incision that's more marked and visible than coming just underneath. And then one goes through straight the tumor, or for access when you're really struggling and you can't find where your frontal sinus is. The mini trephine is a tool, Medtronic, but there is a really good South African company, and if anyone wants basically the equivalent of a mini trephine, get in touch and I'll put you in touch. But essentially a mini trephine allows the meter hole to be made safely. It's much quicker and expect of the medial eyebrow, and you drop straight in. And you can leave a metal cannula in if you're going to irrigate on the ward, or to flush the complications of acute frontal sinusitis. In the past, I've used it when I was doing my fellowship 14 years ago to find cases of revision surgery, and you're going in endonasally, then potentially it's an option where you simply drop in, put a few drops of fluorescein in saline, and you can follow it back up the nose. And now an additional port, for example, repairing a CSF leak or a fracture on the back wall of the frontal sinus, a draft 3 or an orbital suspension, and doing all this radical excision, you can just drop in, do what you need to do, and come out. Let me show you a few cases. He's had a dozen operations before, and he's clearly got hypertelorism, so you can see his eyes are slightly pushed apart, they're slightly proptoed. Obstruction from recurrent polyps. In the UK, in the NHS, we don't have access to dupilumab biologics, so we're still having to operate on these patients. This is his sinus dilatant, so he's just got hyperpneumatized sinuses and happens to also have severe recurrent polyps. Now, for me, is really hard to get through from the nose, so it's one that I elected to do through an osteoplastic flap. So the first thing when you're doing an bony osteotomy, and you can either use transillumination, but you have to empty the sinus first, because if it's full of polyps, it's not going to transilluminate very well. But you can transilluminate through, before you've done anything, through the upper eye socket. So as in this picture on the left, you stick it with the light up and transilluminate, and you see here it marks out. And the thing, or working out where to make your osteoplastic flap is image guidance, but they all give different answers. So if you use that external transillumination, it overestimates the size of your frontal sinus. So you need to go intracranially. Your endonasal transillumination is probably the most accurate at finding exactly where is the edge of your frontal sinus. Underestimates. Now, it's always safer to underestimate a little bit than to accidentally go intracranially and get a CSF leak. When I do my osteoplastic flaps, I do a zigzag incision here because you don't need to. And then I do a zigzag because, especially in men, you'll find that as men start to recede, you will see a straight. And here I'm using piezo to do my external osteoplastic flap. The next step is you work out, now I'm going to take out where your septations are. So you've made your bone cut, but you're going to put in your external osteotomy. And where you're going to put them in is where the septations are. There's no point in me putting my osteotome here because it's more likely to fracture the front of your osteoplastic flap. So I will then put that's the only thing that's holding it, and you'll find the whole frontal flap will come out. That then enables you to combine your endonasal approach and your osteoplastic obstructed mucocele, and then you replate it. Now, the plating, before you do your osteotomy, I pre-plate it first so that my plate goes, who has a chronically discharging fistula just in the upper aspect of the left medial canthus. And he's starting to get early cataract, he's getting cicatrization, so the eyelid, because of constant pus, this is just going to give him a problem with his eye. Let's look at his CT scan. So no surprise, there is a lot of osteotic bone. The frontal sinus is actually very small. It's beginning to manage this. So what operation, what approach? Does it need doing? Well, he's got chronic frontal sinusitis. He's got a cutaneous fistula. So are you going to try and drain this endonasally? And whatever you do, even if you reach this, it's going to close off and reform again pretty quickly. So here I did an external approach, but quite an old-fashioned operation. This is a Riedel's flap up, and then I mark out the bone that I'm just going to chamfer and drill back. So in a Riedel's procedure, it's done for osteomyelitis of the bone, of the frontal bone. And the challenge with this is always, how do you mitigate for that horrible step deformity? So I've stitched that fistula closed, I've excised, it doesn't have this frontal bossing. And then what I do is I take a bit of temporalis laterally and the pericranial flap, and I fold this space. So I'm obliterating using that muscle. And if you look here, this is before surgery. This is, you can see the zigzag on the ward a couple of days after. And this is that, and there is still a roll. Let's look at another case. This is, again, one of my patients. She's a Polish lady who's been on antibiotics for 6 months. She's got chronic and redness. She's had IV antibiotics. This needs surgery. Antibiotics are not working. We look at her scan. She's got a lot of head trauma when she was very little. She's got a bit of an encephalocele coming down, but very complex fracture here, and externally some of the front osteitis. So again, I decided this was really difficult indolent disease, and I would do an external approach for chronic osteomyelitis going in, and just build away that osteomyelitic bone, and then I drape the skin back, and within a few days, that redness has gone. So if you've got osteomyelitis, this lady has got aneurysm clips that she had put in the 1980s, so she can't have an MRI scan. She's already had, you can see, a frontal sinus operation for a right frontal mucocranially. Now, how are we going to approach this? Are we going to go back in endonasally, try and drill here? It's very narrow. Move the floor of the frontal sinus, squashing the orbit to get laterally here and hope that it doesn't reform. Well, I would put to you that this is a good through an upper eyelid incision. This is the true frontal sinus that is on the right of the screen, and that's that cavity intracranially. And I'm going to drill all that back to try and get to the maximum diameter I can to the patient's anatomy weeks. And here you can see through that eyelid approach, I've gone endonasally, and I'm leaving this wide. Some very old approaches that as rhinologists we still need to have the skills to be able to deal with. So for me, what are the take-home size of the frontal sinus, the degree of neo-osteogenesis, the pathology that I'm treating, is it benign or malignant, and then the experience that the team have. And you can't do this instruments without high-speed drills and without, for some of them, image guidance. In the NHS, we have this system called GIRFT, which is get it right first time, and the frontal sinus epitomizes the go and then pass the complication on to somebody else. Thank you very much.
Thank you very much, Dr. for that presentation. ختامها مسك, the last lecture in this first session, for this delay because the program here is different. Sorry. Dr. Hiba is a consultant radiologist and facial plastic surgeon at Awali Hospital, Bahrain.
Good morning again for those who weren't joining us earlier, delivering earlier. And I come in with to share with you the ideas of how do we improve our practice away from the clinical procedures. So practice varies. We need to know, why do we have practice variation, and is practice variation a healthy way forward, or is it this thorn that is actually keeping us awake, how to improve our practice? Care that is provided differently to same patients and similar conditions. So if we simplify this, somebody who has chronic rhinosinusitis, failed medical treatment, qualified surgery to her surgery. And is that a healthy variation we have? It's no different to any other specialty, no different to any other subspecialty in ENT. Very common line, but is this? And if we talk about, the variation itself, we start from simply the indication of the surgery. So now we're not talking about disease, we're talking about surgical intervention in endoscopic sinus surgery in Bahrain, and we want to see how we can standardize that practice. So if we talk about the indication, at what level are we the variation takes place in those patients? And are we listing those patients at an early stage in their disease or at a later stage in their disease? So patient expectation is an indication. At what level you decide I'm going to operate, and what techniques are involved in your procedure. So if this is a frontal procedure, if it's what now the term mini-FES or a minimum endoscopic sinus surgery, if this is a draft procedure, and then the post-operative care. So what are the It exists basically based on the surgeon level itself. So what stage are you performing the procedure? And the surgeon level of training as well. So not the level of expertise, but the level of the department, the surgeon, the hospital, the institution, the society are following. And as I said and mentioned earlier, there is a lack of standardized. There is a variation in interpretation of radiological analysis. So what happens when there is a practice variation? And why is this subject very important? Minimize variation. We need to minimize variation because this is wasting of resources that are used unnecessarily on those patients. The variation outcome or all factors that are guided by this variation. If there is any ethical concern, so equity and care of delivery are all guided by the variation itself, and most important, create confusion for them if they work in different places. Why is this variation happening between one center and another? So we've established now this is going to improve, but how do we set a step forward from there? So setting a benchmark, and the benchmark, are we within safe evidence practice? So evidence-based safe practice for those patients. We allow for development of quality indicators, so the practice itself is monitored, identified, audited, and then we are unwarranted variation. We follow the guidelines at the moment. We have the European position paper guidelines in management of endoscopic sinus surgery, and Professor Rida Kamel in Egypt and his team have also led, which comes out as different consensus statement in the literature, and the guidelines as such is not there, but this is the process forward. And then if we follow audit and feedback loops, and we attending conferences and meetings like this, talking about admitting that there is a gap and there is a loop that needs to be closed. And then, for example, in the UK, we follow the BRS created by the Iraqi Rhinology Society. We have a similar template in Bahrain that we follow for patients. And an important factor in this slide is if or endoscopic sinus surgery or the SNOT-22 audit, which if you see in this graph, you will see there is, as the time progressed after endoscopic sinus surgery, the symptoms recurred. So patients in their SNOT-22 scores after 3 months was far much better than the score after 12 months. So as time progressed, the patient's symptoms have reoccurred. And this is a very wide variation in practice or early intervention or post-operative variation in care. So how is that going to improve our current practice, and how do we move forward? By auditing your practice, by admitting to the level of variation that you're having and being honest and transparent with your trainees and with your fellows, then you're closing that loop tightly. And then in collection will all help to minimize that and close that hole. And finally, I leave you with this slide which talks about a good endoscopic sinus surgery doesn't necessarily mean you as the surgeon are happy with your practice. That might be a patient who is dying on the table trying to be saved by the anesthetist. And that's the pure take-home message. Thank you.
Good time for delayed.
Thank you.
Now we start shield distribution for speakers and
good morning. It's both an honor and a privilege to stand before you today as we celebrate not just a successful event, but the remarkable individual who made from across the globe to share their knowledge, insight, and inspiration with us. Today, we have the special opportunity to express our gratitude in eminent thanks for your contribution to this event. On behalf of the organizing committee of the 7th International Conference of the Iraqi Ent Society, a combined meeting with the 8th International Medical City Ent Conference, thank you once again for being part of this event. Let us now proceed with the distribution of the shield. Alfred Aga. Yes, you can come from. Eduardo Morio Serna. Hiba Rifi. Kogza Lyoka. Livan. Thank you, Dr. Leith. Please, Dr. Firas, to join us to continue shield distribution. Nasser Dadzad. Paul Yazbi. Remo Corona. Sampath Rao. Thank you.
Scan or any other? It depends. If the patient had a previous surgery or if there is any
That was my
condition,
second question. You just passed. Okay, perfect, good.
I may order a CT scan, but sometimes I don't. If I can explore the nose completely and the patient's primary care, order any studies.
So you prefer to do the endoscope, and according to the endoscope, you analyze and decide if you will proceed with the CT.
Yeah, the endoscope and the exploration, it is very important. The tip support is very weak. I will definitely think about getting some drip.
Okay. Dr. Yazbek, what do you think it makes any difference if you have congenital deformity, congenital in your plan and in your progression with the surgery?
Okay, very good question, because the congenital crooked nose, the dome and the cruri, the lower lateral cartilage between the cartilages, and then the repair would be different. If it's post-traumatic, then we know like there is symmetry between these lower lateral cartilages. The repair would be targeted to reverse the injury, the trauma. If it's post-surgical, then exploration is needed to know what's going on, what happened during the first surgery.
What do you think is the most difficult one? Congenital? You prefer to see a crooked nose, congenital, traumatic, or?
Yes, absolutely, generally, because they have both sides.
Okay.
But after traumatic, you can fix it coming to the middle side, but genetically or the...
So if we divide trauma to surgery and trauma?
Surgery.
Same.
Yes.
Even surgery. Okay, thank you. So let's start with our cases. First case, and Dr. Firas yesterday talked about it and explained it in a nice way. Okay. Do you consider this classification in your plan preoperatively, or it's just classification, theoretical classification? Dr. Dadish Zada? Dr. Dadish,
Sorry.
you consider this classification in every case, or it's just in your mind generally?
I don't understand your... Yes.
Yeah, from South Korea. The bone is deviated and the cartilage is deviated, which is tilted.
Just
no
cartilage.
bend. Tilted just like this.
Okay.
Type 2, the bone is tilted. Type 4, the bone straight and the cartilage is bent. And type 5, both bone and cartilage are deviated. They are straight.
To spread the graft, you can fix it. Sometimes we needed to two double osteotomy,
Okay.
maybe, and put the cartilage the other side.
So you have a classification in your mind.
Maybe S deviation.
Okay.
We make it osteotomy, then put the cartilage for the fix it.
So this is algorithm. This is algorithm by Jung also. How to approach for the crooked nose. Now, do you prefer to do the for Dr. Or combined, which is the hybrid? You have any preference, or it's depend on each case?
My general approach.
Yeah.
It's generally structural.
So you prefer structural?
I have to say that in some cases, preservation is better than structural for crooked nose.
Great. Dr. Yazbek?
I do structural with hybrid. I use the part instrumentation, of course.
Perfect. Now, we have this to make a brief plan. Dr. Dadish Zadeh, what will be your plan quickly? And do you prefer to go structural or preservation first in this case?
In this case, take a home projection and tip plastic, but for the correction, deviation correct, that's enough.
Okay. Dr. Goksal, you prefer to go preservation or structural? In this case, particularly? Structural. Okay, perfect.
Yeah. Septal deviation is
Okay.
in anterior septal angle. We have maybe I couldn't see, but maybe have a alar asymmetry. We have
Okay.
open. We can do it. We can try to fix all of them.
Perfect. Dr. Morera, you then proceed.
Sorry?
Your first step is to cover the septum or the bone and then the septum?
Well, it depends.
It depends.
I mean, this is a good case for both structural and preservation. Release the septum, but balance the length of the nasal walls with osteotomies.
Okay. Dr. Yazbek, can you give us a brief? If I want to be more specific, what is your plan for the bone, particularly for the bone?
The bone, there is definite asymmetry. The right bone is more tilted, and the left right bone. Maybe a single osteotomy will do, but I need to touch the bone and feel them before deciding.
So you are going to do
maybe double osteotomy.
double osteotomy,
Yeah.
exactly. That's the point. So you go like conventional, but the addition here is double osteotomy. This is the most important. We do the high, which is the not the good lateral osteotomy, which make the step. And then you are going to resect the bone, right?
The lower portion will fall in a little bit, and then it will correct the bones to midline.
So just osteotomy, no ostectomy.
No osteotomy. No.
Borrow the concept of preservation, and I thought it was a good idea to do the preservation. So what we did, a circumferential osteotomies in all the bones, and then the whole pyramid to the other side. Okay. So, you see here, I did the circumferential osteotomy, and I added on the long bone the double level to here. This is a piece of PPE or the vomer. I want to make it on the, if you saw in the video, the bone is mobile as one unit. This is just like a skin. This is just a look to prevent the pyramid to go back. But we have to put it small, and we later rasp it or burr it with the burr to prevent the memory of the bone. My memory, it's good on the table, but I'm afraid of the long term, so I want to confirm to keep it and to be sure it's on the place. I just put that just to make an oblique suture to bring on to the new side. It's a simple, it's just transfixion suture, oblique for the, or to fix it, not to bring it, to fix it in the new position. And for the tip, we went conventional, just as conventional. And I put a little bit of dice cartilage on the radix because we can see it's a low radix, and when we are managing crooked nose, we have to cover everything. Another case, I will give you a short saddling, and there is a hump. No rhinoplasty, just septoplasty. And we can see how bad septoplasty can destroy the nose, because here we can see this angle change. So, Dr. Dadish Zada, what do you think? How you can proceed with this plan of this case?
Yes, in
part.
That's before the surgery.
Septoplasty.
Septoplasty.
This is after septoplasty, so you don't have.
Have saddle nose and tip. Yes.
And the examination.
You need a rib graft. Absolutely.
Thank you.
For the fixed septum, the Alstrat, and for the bone system, you know. And structure, absolutely structure.
So,
technique.
your plan is to reconstruct the septum and proceed conventional.
Yes. Okay. Then you need some dust, cartilage dust for the
camouflaging.
Okay. Yes.
Thank you.
Because I think do you have
yes, there is a
yes.
facial asymmetry. I just make the zoom in to make the deformity clear.
Yes.
There is a facial asymmetry. Yes.
Yes, and the right side, maybe you need a double osteotomy.
Okay.
Yes,
Tilted.
the middle side.
Thank you.
Yes.
Okay.
That's it.
Thank you. Dr. Coxal.
May I see the bottom view, please? Yeah. There is maybe small pieces is
To remove. You want to remove a small piece of the bone?
Yeah, maybe double osteotomy enough. We try.
From the right side.
Yeah.
Okay.
In equal, it's double osteotomy is enough. But pull down, maybe take off a small piece of the bone.
Okay. So
right side.
But what about the cartilage? Do you think you need to?
If you need, we can do it. If you need, after the we can do it.
Dr. Eduardo.
This patient has mid-rib.
Okay.
100%.
Thank you. Dr. Yazbek, you are going to do osteotomy or just a double level for the bone?
I would ask the patient, why would he do a planned before? Why did he do a septoplasty in the first place? If he's breathing well, then I wouldn't do anything.
No,
if it's just for the shape.
No. He's not breathing well. The nose is completely blocked. He came for a function.
I'll do more of a dorsal reduction on the right side. I don't need to do double removal or osteotomy, but right, with removal, more removal to shorten the bone of the right side.
Exactly,
we'll take a rib graft, do double thicker graft on the right more than the left to put it in.
This is the long one. This is the short. The nose is still like this. All the panelists want to either do a double layer here or to remove a piece of the bone to make this tilt. To tilt the nose like this. That's right, right? To tilt the nose and correct it. So, the question here, Dr. Yazbek already answered.
First, I use the coast technique for the tip because the lateral cartilage is very long and tip.
So and in this case, you will have more hump.
And still from the lateral cartilage with the suture, go up and overlapping the medial resection, maybe a little bit rasp. Enough.
If rasp is not enough?
That's enough.
Okay.
Yes.
Thank you. Dr. Koksal.
Oh, hump or tip?
No, the hump. Because here we have hump, and it's the dorsal.
We can reduce is cartilage hump by scissor, by
cutting
cartilage hump. The dorsal reducing for hump, bone hump.
Okay.
More, for example, is more in right side.
Perfect.
Left is more less.
And what are you going to do for the saddling in the supratip area?
Yeah. I am looking is a key word, key point is very important for we don't want to distract. I am saying, but is a tip very, the alar cartilage is very big.
Okay.
And droppy nose is we can talk
Okay.
later.
So
maybe if you want, you can.
You are going to compensate the.
I am together. Not only dorsum, not only tip. I am considering in
combination.
the operation together.
Perfect. Okay. Dr. Morena?
Yes. This is tricky. I mean, this is a hump, but radic is slow, and we have a saddle nose. So it is not just about lowering the hump.
Exactly.
We have to raise the supratip, we have to raise.
And also, I can add this comment, the angle is changed due to the resection.
Another thing is that it's a crooked nose, and it's a secondary case. So you have to add all force. We have to rebuild the supratip with a Stendeck spreader graft and a caudal extension or replacement graft that will raise the supratip area. And in case we need further raising.
I wouldn't worry much about the supratip area. It's a mild depression. I don't think it's called saddle in this case. I've seen primary cases with hump and bulky tip with supratip depressions like this without
so true. In the laptop, I think it's a little bit different because squeezing the dimensions, he has some sort of supratip depression.
And then we have to fix it as Dr. Eduardo said.
And putting in mind, we don't have a
position in projection and rotation, then see how much depression I have, and accordingly I will
and
deal with
the septum, because the nose is completely blocked. Completely.
Of course.
Okay. Thank you. So let's see the actual plan. What we did here, complete reconstruction of the septum. L-strat reconstruction of the septum. The vertical segment, and the horizontal segment, and we need a strong lamina. Strong, thin lamina is the key in such cases, not to block the airway again. And then this is on the right side of the screen. This is the vertical important, is to fix to the spine. Any one of the panelists just put the reconstruction on the spine without suturing, or you agree, all the panelists, that we have to fix it?
In the midline, then we put it.
If it is not in the midline, what you are going to do?
We can do a trapdoor if it's off midline, but if it's so much dislocated, then it will show to the outside.
So you prefer to relocate it?
Or if it's too much dislocated, then we have to remove as much as we can and fix down.
Okay. Dr. Dadishzadeh, if the spine is tilted to one side, but a crest of the spine,
yes,
blocking the other side.
Sometimes I rasp it and hold with the piezo in the ball and fix it.
So here we can see, this is the horizontal segment of our L-strut. We want a strong foundation. Fix it there, 2 or 3 layers on the horizontal and 1 strong layer on the vertical segment. And we can add 2 segments, it depends. I lower the bony part, and then I resurface with the SPLF, and the panelists said we need to resurface to get a fine dome. I did our SPLF, which is the, because we have the rib and we have the luxury to play with the rib, so I did that construct and I launched it to the nose over our new dorsum, aesthetic lines. And this is launching of our SPLF. I will pass it quickly. On the right side of the screen, we just launch it, and on the left side, we are trying to suture it. And this is on-table result. You can see it's very important, the nasolabial angle, we have not to miss it. We should not just focus on the dorsum. Again, the dimension of the screen make the screen narrow. It should be wider screen to show the proper dimensions. It's clear, it's not just a deviated nose, it's a wide nose. And this guy is a sportman, and he's a kind of kickboxing, and he had a lot of sportmen or athletes to retire before doing the surgery. Dr. Dadishzadeh, or you keep on with the patient, his violent sport? Wide, yeah.
And after the trauma, the cartilage, maybe the fracture inside, maybe deviation left side. First, I fixed it.
I just want to add, he did not fully obstructed, but he's suffering.
Maybe I have a septum perforation.
No septal perforation, no.
Okay. What might think about this surgery? You want to?
So you ask him to leave kickboxing, or it's fine to do the surgery and he complete his life with the sport?
If you want to continue to sport?
Yeah. After surgery?
No.
No. Dr. Coxal, with all previous septoplasty, do you think we need to harvest a rib?
If you continue the
No, not about the sport. He did septoplasty, he's suffering, and now he wants to solve this issue. Are you going to ask the patient for a rib?
When they open, I try to, for example, before the cases, like in right side, more longer looking is the other side.
Okay.
If you need any cap,
okay.
we can try to fix this.
Perfect.
All of bone, we have to osteotomy, make osteotomy, make it flexible.
A little bit in such case?
Okay, first I want to say, I have these patients coming to me and I tell all of them, when you stop having people kicking your nose, you come and visit me back. Okay. Until then, forget about surgery.
Forget about surgery.
Second, he had previous septoplasty, and he has his nose demolished several an optimal outcome unit
With rib. Okay. Dr. Yazbek, what about the dorsum? Are you going to lower the dorsum or no? This dorsum.
First, I tend to agree. The internal valve collapse. We will do spreader grafts, keep the bones without fracturing them. This will open his internal...
You keep the bone without fracturing. How you will solve the width? You don't ask him to retire from sport?
Look, it depends on the sport.
It depends,
Kickboxing, he will continue having injury to his nose. But if he's a basketball player, a mask can help. Kickboxing, mask... Yes, I would lower the radix. It's a Roman nose. It's a high radix nose. We will lower the radix.
Exactly.
And keep the bone to follow the newly formed radix. Personality. And then we need rib in this case.
So you are going to lower the radix, keep the dorsum, maybe increase the projection of the tip to get that straight dorsum, right? That's
use it to like boring what
yeah,
sculpture. Without osteotomy, you can use a little bit the
the pictures may not show the proper or the actual deformities. It was a very wide nose, so yeah.
You can see is a high radix.
High radix and low deprojected tip.
Yeah, and you can see is a sepal luxation. You can see the left side is a sepal luxation. Related to is tip looking the widen will down.
Okay.
I think that is a alar cartilage asymmetry. But it's a congenital situation. Behind the open, we can see is a alar cartilage asymmetry.
Alar asymmetry, yeah, that's true. Okay. You see, the septum SMR is very clear here in this video. There is an SMR is already done, so we don't have any cartilage. The bent is clear. A little bit relaxed, but it was more than this. The saver in this case was that I found PPE, I fashion it and I support my thumb and fix it on the midline. Was a very important segment. Again, suture it to the spine. We can see after to keep it in the midline to suture it to the spine. And it's very important step also to either to relocate the spine or to make confirm our new position in the midline. And here what I did for the bones, I did all the osteotomies and I added osteectomy for this line because it was really very wide. And see, it's a big steel for the tip to raise to deep to increase the projection. You can see the first line, the one at the original dome, and the dome projection by stealing. Okay. Here in this, the frontal.
If you steal from the lateral alar cartilage on it and overlapping in the middle.
Okay. So here, overlapping or you push it down or articulated or alar rim graft? Just overlap?
Overlap with the
alar was retracted like this. And we are going to tilt the nose like this, so I expect to have more retraction at that side. And I did. This is the end result.
For me?
Yeah. No, I'm just. You want to comment?
Yeah. In lateral crura, you can. Maybe you can do it.
Okay. Thank you. So this is the I think it's the 10 days result. And we see retire from sport, and he confirmed that he's going to retire, and he moved to be the coach instead of getting the hits, and that was the deal. He promised me with trauma, I will not touch him and I will not do anything for him. And he was honest. So you can see the profile. I didn't lower the hump. I just raised the pass quickly for the sake of time. We have this severely crooked nose. And we can see we have a Dr. Dadizadeh.
Yes.
Huh?
In this case, you must remove the hump. Okay. Double osteotomy in the left side. Use the cartilage.
He first consultation was at his 17. Okay. I refused it. I told him to postpone at least 1 year. Then he.
After they remove the hump, you can osteotomies and maybe remodeling the cartilage, septal cartilage remodeling. You can bring out and sorry.
Complete obstruction of the nose. Do you consent for a rib?
We can use it this side. I don't know what inside.
Exactly. So, are you going to consent the patient for the rib just for your safety? Are you going? Sorry. How do you manage the bones, particularly the bones? We can see on the left side we have a very long bone. On the other side, this one is very long and this one is very short.
In these cases, I think that maybe the bone is a very short, looking short. We open, try to think that is left side more longer.
The left is longer, yes, definitely. Yeah. So you are going to do the double level or osteotomy?
Double, if necessary, if enough. Double.
Okay. Okay.
From the left side.
Okay.
A small pieces bone.
Okay. Thank you, Dr. Eduardo.
Okay.
You have important thing to say
key
because
thing,
I have important question for you.
Yeah. And this is attention now.
Okay.
Cartilage has grown too much and has twisted everything. He has a nasal hump. Until you fix the nasal septum asymmetry on the lateral nasal walls, you will have to do either double osteotomy or ostectomy on the left side, and you will have to somehow release.
That was my question. How do you manage this? The bone is completely tilted.
A radix osteotomy in this case.
To do a root osteotomy. A root osteotomy, right?
Yeah, here. Yeah. Unless you do that, you won't be able to the midline. But you have to be very careful when doing that because it's very easy to sink the whole radix area. So instead of doing a vertical osteotomy, you have
kind of step to keep it in position. Not to make the collapse.
If it collapses, you still can camouflage it, but you don't want that. You want it to be...
And the septum, you make the L-strat construction from the rib, conventional.
That's a huge septal deviation. So the cause of it is that the size of the quadrangular cartilage, you have to reduce the size of the cartilage and you need to get cartilage. I don't think you may, but I don't think that in this cartilage.
So it's like you open and see, but you can set the patient for the rib and open and see, right?
Yeah, but I would say that 95%.
What are you going to do for covering the alar asymmetry and the columellar is already hanging in relatively, let's say. The alar the left side is retracted and the right side, and after correction we may have a new position of the alars. So how are you going to cover this?
Okay, this is what we said earlier. If it is since a long time, then the ala had developed to be hypoplastic.
Okay.
And then in this case, I would to rib, but and then when you finish setting up the whole dorsum and middle third, then at the tip you will definitely see some asymmetry, especially a weaker need to put grafts and fix it to match the other side.
Okay, thank you. Dr. Dadish Zada, do you think if I am a beginner, it's a good case to start with? Is it
Yes. And when they fix the you bring it middle, the septum cartilage is growing down.
Yeah. Dadish Zada was trying to cover. This septum is completely bent. So, surprisingly, when you are correcting this septum, we will get longer septum. That's your fracture. So we have to save ourselves. What we can see here, it's complete. Okay. The plan in this case, I did extracorporeal plasty. Fortunately, I didn't need the rib. I consent for the rib, but I didn't need it for the issue that Dr. Dadish Zada explained, that the length of and right bone medial oblique with one level. And for the hum, I dealt with that with our technique that we publish it, Casal Ropotti Ferreira technique. Briefly, it's a combination between resection here and resection banana shape. And I will show this briefly. We did the cut just where the hum starts on that, and then that side out. I think I don't have a time to explain this procedure. It's our new technique. We just lower the dorsum as a segment, and this is the last case. I want to thank the for the AILA we did a complete transposition again, because it was the different aspects from different panelists from different countries all over the world. Thank you for joining us in our panel and in our conference, and hope to see you soon. We close? Right? Right now? Okay, now we are going to start.
Enrico answered.
Really?
Yeah.
Ent Society. Please let me introduce our first speaker, Sampath, and his first presentation, simultaneous ipsilateral hearing implantation alongside the skull-base surgery. Please join me in welcoming him.
Yeah. I enjoyed the previous couple of lectures. So this one will deal with simultaneous ipsilateral implantations alongside skull-base surgery. So those are my courses. I've been telling about this to a few of my Iraqi colleagues here. We run one of the largest courses in skull-base surgery anywhere in the world. 10 days of lateral, 10 days of anterior, and then shorter courses. Welcome to Bangalore. So what's very important in understanding skull base with implants is about what we call subtotal pit. Doing a blind sac closure, so your cavity is completely sealed from the external environment. And most of what I'm going to talk to you about is going to come from this paper that I've quoted paper in subtotal petrosectomy. So what is subtotal petrosectomy? You go in, do whatever you want, create a large cavity, remove all the cells. The basic approach, which involves remove approaches, but basically you need to create a cavity which is not communicating with outer environment. So you're talking about blind sac closure and closure of the stitch and tube. and then filling this cavity with fat. So let's go to the first case. Now, before I go to the cases, let me very clearly explain what happens when you do a You have a artifact, right? So this artifact looks like this. Okay, so this is an artifact due to an MRI, which is due to the artifact reduction sequence. This is a bilateral cochlear implant. Look at the artifact. It's a very big artifact. You can see nothing. You can't see the brain. But when you use an artifact reduction sequence, the landmark difference, and this is the reason why I'm able to do a magnetic implant, whether it's a cochlear implant or a bone-anchored hearing implant, osseous, are called the maverick sequences. So this is the bone-anchored hearing implant of the yesteryears, what we call the Baha or the Attract system, the connect of the Attract system, of course. So this is a patient from Iraq, by the way, pluri-operated. Let's cut to the chase. So this is his scan, a big lesion here, which is a petrous bone cholesteatoma. So that's the scan. Okay. So the CT scan obviously shows a big, I used to place it vertical. So this used to be a vertically placed ossia with a transducer here and the receiver stimulator complex here. I go in. So those are the fundamental steps of ossia. So this is operated 4 times. He was operated 4 times before he came to me. Very difficult to do a blind sac closure. So here is the cholesteatoma coming. Orthotic approach, try to preserve the facial nerve. This is a 10-year-old facial palsy. He came to me after 10 years of facial palsy, so there was no current passing through the nerve. I tried using the nerve monitor, and there was nothing. There was no cholesteatoma removed. Then I place an ossia. But mind you, I've started doing osseas after doing hundreds of skull-based cases. So I know never do this in a case where I have left behind some tumor. Okay, so this is bone-anchored hearing implant, BI 300, on which I is to make sure that there's no contact of the transducer with the surrounding bone, and then you have the implant being placed like this. It's a fairly straightforward process. We also did a facial contour surgery and a lid loading blepharoplasty, lid loading lateral canthopexy, all in one sitting. Okay, so this is abdomen fat. My facial plasty correction of the face, and this is to be followed. This was done a couple of years back. This is to be followed with static and dynamic procedure. The first step is to do a contour correction because he's got a flat face. Grade 6 for 10 years. Okay, so hearing 100% restored, facial contour restored, all in one sitting. He underwent surgery for close to 18 to 20 hours. This is another guy with petrous apex for 6 months. And then he develops, his problem doesn't become all right, but he develops a lateral rectus. It develops a lateral rectus palsy after 6 months of IV antibiotic. Now I go in, I have to save his vision. His hearing had already come down, but his disease is all under the carotid bed. This is the petrous carotid. You see the disease coming into view. I cannot do a middle fossa. The next question will be, why didn't you do a middle fossa? I cannot do a middle fossa because the disease, this is the petrous part cleared. Now this is the carotid, vertical, genu, horizontal petrous. I go under the petrous, I see disease. This is disease. This is disease. I remove it. Then I do a carotid transposition. I push the carotid from the carotid bed, and there is pus. You see there is pus in the carotid bed. I cannot do a transposition with the middle fossa. Okay, closure, ossia. Ossia implant, I used to do a vertical implant. Now you see within 2 days, post-op, second post-op, his lateral rectus is corrected, completely corrected. Okay, so that's his post-op scan. This is an ossia. Okay, so that's how his post-op looks like. This is more than a subtotal petrosectomy. This is a transaortic approach, okay? Like this, I keep a shelf of or a sleeve of skin so that there is no connection between the cavity. Obviously, a translab approach means that you're going into the CP angle. There's a lot of CSF. I don't want that CSF to come into the ossea cavity. So that's how all these are ossea modifications, not mentioned in any textbook or in the middle fossa dura, sigmoid, presigmoid, high jugular bulb. I go in, internal auditory meatus. This is the CP angle. I go in. So this is not a presentation on translab, so I'm going to cut to the trigeminal nerve. I go in, I leave behind some tumor because this was a cystic tumor. If you had seen, I leave behind some tumor and then I do a ossea from behind. I can use this incision, but I don't use it. And then I do the bone bed indicator, blah, blah, blah. And then the ossea goes in and it's covered. So that's his post-op. He's got a grade 3. And I'm keeping. He's got a small residual. But my ossea, this is the artifact. This is without the artifact reduction sequence. Sorry, this is with the artifact reduction. This is without. So I can see, you see this residual? This is what I'm in touch with a lot of Iraqi neurosurgeons, by the way. They are participants in my courses. So this is my neurosurgeon who is now happy with me doing a ossea for a retrosigmoid approach. So you see, he's put in, go in, place the ossea in front. So this is the exposure, suboccipital exposure for my neurosurgeon. I do my work in the beginning. I put the ossea, and then my neurosurgeon operates in the suboccipital area. Okay, so there you go. He starts working, and that's the dura. So that's the infratemporal fossa approach. So this is a C3 paraganglioma. C3 paraganglioma. So I'm just going to go through I showed these pictures yesterday in my paraganglioma presentation. Mastoid. Now I do an ossea right in the beginning. Okay. BI 300. I put in an implant. The template is put. Bone bed indicator. Ossea goes in. So then I go ahead and take out all of the tumor. So yesterday I described to you, so the blind sac is here. I do the blind sac. I bring the canal wall down. I told you about the extreme fallopian bridge technique. This is the fallopian bridge technique. Now by releasing the jugular process and by drilling out the jugular process, you get exposure from behind. Then what you do, facial nerve, styloid comes out with the stylomastoid foramen, and then lo and behold, you have a huge exposure of the posterolateral exposure from only if you remove the styloid. Remember, this is not the hypoglossal. The hypoglossal is here. We're very high up in the skull base. That's the parapharyngeal carotid getting into the petrous carotid. So this is the last part of the tumor. The tumor is being removed from the petrous apex. The jugular foramen is already removed. This is the petrous carotid, completely free from the tumor. So that's how it looks like. I told you about the extreme fallopian bridge, isn't it? When you have the MRI. This is very bad. But with the same patient with so this is MRI without the artifact reduction sequence. This is the same patient with artifact reduction sequence. So I'm able to follow up all my magnetic devices. So now you see the reason why I have moved the ossea from vertical to horizontal, because you get both the reduced artifacts in the same straight line. So you don't get it in two areas, you get it in one area above the surgical area, Otherwise, if you put it vertical, you get one not mentioned in any literature. So that's the. So I think I will skip the ossea and I'll show you. So this is another ossea in a skull base osteomyelitis. Look at this. This is really difficult surgery. So this is mess. This is a mess. I remove all the disease. This is skull base osteomyelitis. Now we have one of the largest series, 280 treatment for skull base osteomyelitis. You cannot treat this medically, okay? So these patients, you see this disease, terrible disease all over, everywhere in the skull base. This turns out to be a fungal. So this was being treated as bacteria. The styloid being removed. I am removing the styloid here from medial to the facial nerve in a subtotal petrosectomy cavity. That's the styloid process. It's coming. swabs. So this is decomposed styloid musculature. I'm going under the styloid, everything cleaned up, okay? This is petrous, this is carotid, this is petrous, this is the petrous carotid. And now I put the osseous implant. So the patient begins to hear absolutely during the same sitting. I know that this is, okay? So that's the implant again, artifacts with the implants, and then without any shadow. So this is with shadow. So where's the one without the shadow? Let me see. So that's the artifact reduction sequence. You see, the entire area is free from the artifact. Absolutely. This is fat. This is the fat which I've placed in the cavity, okay? So I'm going to skip some of the slides and show you cochlear implants, okay? So reduction sequence without which we couldn't even think of these things, okay? I'm going to skip a couple of cases that I showed you yesterday. Now, this is, I'm just going to show you a very interesting case. Okay, yeah, this is the guy. Let me show you this case and I'll wind up. So, this guy, Association from Mumbai. You see disease here, refractory disease, and he's elderly diabetic, 70 years, palsies, facial was in fact intact. And then I told him I'll have to do a subtotal petrosectomy, we need to take it out, look, could be fungal. And then I did a BAHA for him. I did a BAHA. I told him this will bring your hearing back. I did a blind sac, and then I go in, and then I find that this is after about 8 to 9 months of treatment. A lot of disease inside. You see that there are micro abscesses around the stylomastoid foramen. The tympanic bone is eroded. I have decompressed. I have skeletonized the petrous carotid. So that's disease in the jugular foramen, sigmoid sinus, severe to profound mixed hearing loss. So there was not a problem for me to put a BAHA and do a subtotal, nothing. He's not losing much. So this is, look at this. This is a mess. His clivus is eroded. Entire petrous mastoid bone is involved. The clivus also is moth-eaten. This was fungal, aspergillus. He was given antibiotics, IV antibiotics for 8 months. This guy is a billionaire, not a millionaire, but a billionaire. Okay, he's got 2 unicorn companies in India. This guy, and disease on the left side in 2 months. He is already on amphotericin. 2 months, 1 month amphotericin, IV amphotericin. He has now disease on the opposite side. And he's lost hearing. Now, I told him this is even worse than the first side. I said I have to do a subtotal petrosectomy. I have to do a blind sac, but that means you are losing hearing in the only hearing ear. There was no other option but to save his life, because we know that this could be fungal. Okay? So I go in, normal external ear canal. It is wrong to talk about skull-base osteomyelitis as disease of the external ear canal. Fungal skull-base osteomyelitis is a disease originating from the external ear canal going into the petrous apex. Now you see, in a normal tympanic membrane, the mastoid is normal. You go inside, looks normal, nice and clear. You see disease in the petrous apex. This is jugular foramen. Go ahead, remove. Looks normal till now. Now you see the disease in the petrous coming out. It's coming from the opposite side. Okay? The entire petrous, so this is the carotid area, this is the cochlea, infracochlear area. Disease is the infratemporal fossa, anterior to the carotid. This is the carotid, this is disease, this is massive disease in the infratemporal fossa. This also turns out to be fungus. Fossa. This is disease in the hypotympanum, deadly disease.
Sorry.
Yes.
You have exceeded your time, please.
30 seconds and I'll finish it, okay? So at the end of it, laterally deaf. What do? I wait for 6 months and then I I remove the baha and I do bilateral. For the first time, you will see what is osseointegration. So this is removing the baha. You see I had never seen this before. Osseointegration. You can see it only when you remove the baha and then I put in a cochlear implant. Okay? So that's cochlear implant steps. CI630, he goes for the best. I have no problems. If he wants to, the best, we give the same sitting. I open both sides. After 6 months, after repeated scans, which are normal, I go in and put a cochlear implant. Okay? So that's bilateral cochlear implant. So this guy is disease-free for more than 2.5 years now. And I'm going to meet him on Wednesday. I told you he's my biggest ambassador. Got bilateral fungal skull-base osteomyelitis. He's hearing in both the ears. Thank you. Thank you. I'm sorry for the... Thank you.
Thank you, Dr. Sampath, for that insightful and pioneering presentation. Professor Remo Corona from Italy, and he will talk about combined approaches for maxillectomy.
Okay, thank you. This is one of my favorite issues of tumors. The one from the oral cavity, maxillary crest, and also hard palate, and the one from the sinonasal side, so pathologies. As you know, we have a very long list of possible classic surgeries for this. Important thing to remember is that the really kingpin of the maxillary sinus is the pterygoid. The pterygoid is the posterior margin of the sinus, and the muscle and the supraromedial portion of the masticatory space, so the most critical area. Moreover, the pterygoid, for the maxillary cancer. How to reach the posterior wall of the maxillary sinus out of these tumors as last part. And this is very, how I can say, not very comfortable to manage. From the endoscopic view, you can face this part as the first part of the surgery. Yesterday, I showed you the possible approaches to the posterior wall of maxillary sinus. This is the we are on the right side. You see the projection of the pterygopalatine fossa that is in front of the pterygoid process, the ITF, the recess, the alveolar recess, that is the floor of the sinus. This is just a schematic representation of the posterior, and then we face the upper parapharyngeal space. Here, anatomical sum up. Anyhow, when you remove the pterygoid, you are in front. This is an experience from the group of Brescia about the management of maxillary sinus tumor with the combined endoscopic approach. You see that they publish a very approach to maxillary tumor, and I applied that especially on a homogeneous series of doesn't work. You see below to the right that my working area is the wall, posterior wall of the cell, only on the medial part. So pterygoid process, pterygopalatine fossa and pterygoid process. So I reduce my endoscopic maxillectomy to a type B to avoid about the compartmental resection of the masticatory space in case of retromolar trigon oral cavity cancer. and then I manage the tumor from the transoral view with a transoral resection or maybe a midfacial degloving. And I call it type 1 combined resection. This is what you remove in this, like this. And then, if I have a massive infiltration of the infratemporal fossa, my margin becomes the masticatory space endoscopic view, but I also add the sacrifice of the mandibular ramus together with all the masticatory muscle and maybe with the zygomatic bone. Gentlemen, with a PT4A alveolar crest tumor, you see there the endoscopic phase on the nasal septum, the endoscopic map, the pterygoid, pterygopalatine fossa. I expose the pterygoid and then I cut it more. And I did almost a simple, a partial midfacial degloving. Then I cut the bone in the oral cavity with the piezoelectric surgery, with the pterygoid process there. So, this is a type 1 bilateral. You see a huge tumor not abutting the whole palate comes out without any concern. You have just to cut the insertion of the pterygoid medial pterygoid muscles on the in a block and block resection. You see the specimen with both the pterygoid, one pterygoid, the right one, second one. This is, by the way, the results in which we take it out everything and block with the infratemporal fossa. Is abutting the posterior wall of the right maxillary sinus and also the skin because it was a neuroinvasive tumor going along the infraorbital nerve. I drill down the basis sphenoid and then the open phase, the open surgery. What is important to see?
2 minutes left.
Okay, I have just another. This is the drilling down of the coronoid process to open up the infratemporal fossa, all together with the muscle of the infratemporal fossa. Okay, last case. Very huge infiltration, by the way, of the wall without first an endoscopic approach. You leave there the tumor if you go only by lateral side. The cutting of the basis sphenoid, and then the cutting of the orbital apex from the endoscopic there. This is the mandibular ramus, cutting down it. And all together, it comes out with the wall masticatory. Case in which you have just an abutting on the posterior wall, if you do the type 2 resection, you can have a ceteric space in the mandibular ramus up to the nasopharynx. Thank you very much.
Okay, thank you, Professor Remo, for sharing us your thoughts, ideas, and the great work. Now let us welcome our next.
Hello again, thank you. You can use a flap or graft, multiple, like this, skin sliding flap. And here you see the auricle. Okay, this case is the biting from the dog. And a nostril due to repair. It's very big. In this video prop view from the various angles. Be repaired with the red line and schematically this like this lateral cruise, and then the columellar flap. I open the video for you. On the defects side and is sutured onto the lateral cruise repaired with the V-flap as in the video. You can see lateral cruise. Okay. Then after the repair, skin, maybe you have a millimeter extraction and towards the caudal. Then nasal splint like this. It is fixed with plaster. When retraction with skin toward the caudal with the suture, we put the plaster. On structure. And here you can see the before and 3 months after the surgery. The vestibule same size, not perfect. Before and after front, 3 months. Not bad, but acceptable. And I presented this technique for the first time, again and again. In 1945, the time required for the information to be doubled was 25. Study in the university for the 25 years. And today, the volume of the information double every 12 hours. For your attention. Thank you.
Thank you, Professor, for that presentation. Our next speaker is Professor Levent from Turkey. And his presentation.
Okay, thank you once again for the introduction. My topic now is ossicular reconstruction with glass ionomer surfer. Until 2004, we were using autografts and prostheses, but 2004, we started to use cement, and this completely changed our philosophy in the management. We use this cement with intact stapes where the malleus in incus are defective. So this is the area that we applied sometimes to stick the autogenous ossicles in incus defects during stapediotomy. Why do we use this? Because it is very effective, very important. You know, the most important thing is the nurse preparation of the cement. The mixture should be sticky, but if it is too soft, effective, so it has to be sticky. And cement should be applied to the bony surface. And as a surgeon, your job is to keep the area dry. And this video is prepared by a nurse. He takes 1 spoonful of this cement and puts just 1 drop of the liquid. And this is my nurse, prepares the cement. What am I doing now? I keep the area dry. This is very, very important because if the area is wet, it is not. She mixes this a little bit more. You see, now it becomes sticky, and this is the time to use it. Your job is to keep the area dry. You see, now is the time to use the cement. So, incus defects are the most common ossicular defects, and we see this situation very frequently in our practice. Brain healed, but look, the ossicular chain is hypermobile because you will see that there is a defect. Maybe around 20 years. So we apply the cement to the bony surfaces and we wait 3-4 minutes until it, and this is the postoperative audiogram of this patient. We can also use the cement between malleus and stapes, which is very important if we use the cement. But if we use the prosthesis or ossicle, relative position of malleus and stapes is very important. The longer the distance, less successful is the called manubriostapedioplasty, where we can use this method when the incus or malleus is fixed and stapes is mobile. So we apply the cement, we cut and remove the head of the malleus, incus, and we only have the manubrium. So there is no chance for refixation. We apply the cement between malleus and incus. Look at this example. So we have a windham is very good in creating this system. So relative position is not very important. You will see of the round window reflex here. Okay. We can also use this for stapes defects. This is also very helpful. Sometimes we show you one congenital case. So this was a 7-year female patient, and her sister has exactly the same pathology. I operated her as well of middle ear exploration. The tomography demonstrates that this is the lateral semicircular canal. Oval window is very thick, and the soft tissue here is what? Facial nerve. Suction, and with a perforator, I perform a vestibulotomy, and you cannot put the piston here because the facial nerve is there. What we should do is extend the incus like this and apply the piston here. So my plan is to apply the prosthesis in an oblique way into the fenestra that I opened. So this is what I do. The piston, check the mobility, and this is pre-op, and this is the post-op audiogram. I then operated the left ear, and then I operated her sister. Once again, we can have this preoperatively diagnosed and also manage this case. Complications, we can have granulation tissues on the tympanic membrane if the cement is touching the tympanic membrane. Particularly in the past, because I applied 1 over fibrous tissue, it didn't heal properly, and also on a wet surface. We divided them pre-operative, early post-operative 3 months, and late post-operative after 2 years, and this is the pre-op, and as you see, late post-operative thresholds did not change over the time. So this is the outcome of our study. So the advantage is it is very effective. The cost is low. This cost by residents, they also do this in operations, and sometimes inoperable cases can be operated, as we see in the last patient. But be careful with the preparation. Facial nerve and oval window is very important. Some ruins. You know, these ruins are 2,200 years old. Look at this structure. It's fantastic. It stays until today. It come afterwards. So this concludes my talk, and if you pay attention, I think it's a very useful tool to use the cement for ossiculoplasty. Thank you very much.
دكتور حازم محمد الطائي.
Assalamu alaikum. Good on sigmoid position and euro position, and also about the alternative and the standard approaches, and also about the features of the round window regarding the visibility, the shape, the prediction of cochlear implant difficulty, and the microscopic and endoscopic view. And of course, if I had enough time, I'll speak about the systematic review of mastoid pneumatization. As you know, regarding this, the mastoid pneumatization is evaluated as the group, and to moderate pneumatized and good pneumatized group, And finally, the hyperpneumatized. The axis in reference to the, according to Han, it is to the malleocaudal joint. And also, this is another, this is a classical semicircular canal also. And these are the diagrams for this classification. And also, these are different patterns of mastoid pneumatization, and difficulty of this hypopneumatized group is there is risk of low-lying tegmen, which may lead to dural exposure, meningoencephalocele, CSF leak, and meningitis. Sinus position, which is also either in normal position or lateral position or anterolateral position. And it is, sometimes it might be bilateral or the malleocaudal joint. And these are two classifications, methods about the Park method in relation to the basal turn of the cochlea. And here the same classification. And this is a proposed classification, sorry, it is a proposed classification by the Mario Sana group, which is a combination of both. In Egypt, about the bilateral cochlear implant and the procedure that I have done by harvesting the bony chip at the start of the surgery and then denuding and ending with the insertion. And I'd like to present my case about the, this is an Iraqi patient, this is the anteriorly displaced sigmoid sinus that the hand of my resident, Salwan, Shukran Salwan. This is when he's holding the, after denuding the sigmoid sinus, the start of dissection of the drilling, sorry, at the site of the facial nerve and the area of the posterior tympanotomy. And here the open. This is, here we are going in the front of the facial nerve. Still, this is the Freyer dissector held by the, my resident, and here this is the drilling on the area exposed now. This is the mucosa, which is a bit, this patient has got otitis media effusion, but, and gel foam for the sake of the insertion in a safe procedure. This is also the cadron drop. Using the electrode in this rapid maneuver, it must be very slow at the time of insertion. And this is complete electrode is kept in the area of Hadidas and antrum. And seal. And now we apply this bone dust soaked in rifampicin, the sigmoid sinus that was denuded of bone. Is the position of the tegmen in relation to the lateral semicircular canal, which is the normal position here, and this is a very low position. Of course, at the coronal view, and this is the small one. And the approaches, the standard approach and the alternative approaches to the round window, of course, the standard approaches is also the cordofacial angle, which is about 25 degrees, the position of the facial nerve, the position of the round window. And also, this is the axis. Microscope at the time of surgery, and here this is the gate between the chorda tympani and the facial nerve at the end of our posterior tympanotomy. And the alternative approaches, the too many alternative approaches, his name, but he escaped. This is the split ear canal. This is his procedure, and I have a presentation that, a diagram that I show you. Standard approach or the alternative approach. When the mastoid segment of the facial nerve lies posterior to the level of the round window, to the level of the basal turn, this produced during cochlear implant surgery. But if we have it, the mastoid segment just anterior or lateral to the position of the to be difficult for insertion during surgery. And this is the relation, this is the posterior, and this case it is expected, this is the mastoid segment of the facial nerve. This is, I'd like to show you our patient. This is our patient where we expected preoperatively from the CT scan that this will be difficult because this is the area of the facial nerve which lies just anterior to the round window, which make it difficult. And this is the view of the surgery. Sorry. Why it's not working? Yes. So this is the trunk of the facial nerve. Exactly what we expected from the CT scan, so which is here. So we went anteriorly and we sacrificed, of course, the chordae tympani for the sake of better view of the round window. This is the completion of the round of the. I have to go fast because the rest of the steps is not present. The second matter is about the round window visibility and accessibility. We depend on the 3, which is 0% of the round window can be seen. And it's expected, of course, that it is more difficult in children than in adults. And it's not visible, and this is accessible, and this is not that accessible. I mean, the depth of the posterior tympanotomy here, it is more deep, making the insertion round window shape, although it is called round window, but actually in the anatomical studies, it is stated that more than 30 shape of the round different shape of the crista fenestra. And here another anatomical studies which shows the relation between these are anatomical studies, and this is also in the radiological assessment we have also 4 shapes of the round window: the tunnel shape, triangular type, and semicircular type, and even a closed type. Regarding the cochlear rotation, Lloyd is the first one who introduced. This is in the axis. As whether this is the normal, this is complete exposure. When the angle becomes bigger, it will be rotated cochlea, and it will be much more minimum degree of accessibility. Above it, it will be difficult to be inserted. And too many studies about the prediction of the cochlear implant, and all of them about the angle of degree of adjustment and degree of freedom, and this must be done in a preoperative period. And also this the same type of assessment of the rotation of a cochlea in relation to the ICA. If it is parallel with the basal turn, it will be expected to be easy, but if there is an angle, it will be difficult. The same procedure, and another classification with the relation of the basal turn with the posterior meatal wall. Again, if it is parallel, it will be easy insertion, but if it is transected, it will be much more difficult. And these are the items and parameters that should be identified in a preoperative period. And also another classification making the posterior tympanotomy as wide as possible, and also by removing the bony overhangs around the round window to expose the 100% of the round window. These steps about the thinning of the posterior meatal wall, exposition of the chordae tympani, exposition of the facial nerve, and also delineation of the lowering of the pyramid, the visibility of the round window membrane. And this is in this study, this is the diagram of these procedures. And this is invisible This is type 3, which is converted by removal of the posterior part of the posterior meatal wall to make it the view better, and to because changing of the angulation of the microscope and the site of view will make the view much more easy to be gained. This is the illustrations of the he went away about the removing of part of the posterior meatal wall. Then at the end of either he removed that bone or he pushed that bone with the skin of the procedure. He used the fibrin, sorry, not the fibrin glue, the cement. Although it is mentioned in this study about the fibrin glue, but in his study he used the cement bone, and this is the post-op view after 1 month. The microscopic versus endoscopic visualization, always the endoscopic view is much better than microscopic view, although endoscope, but it is said in the studies because this is the microscopic view and this is the endoscopic view. In the microscopic view, it is type 3 xanthomas, while in endoscopic promontory, the round on the area here is completely hidden by